Hi, this is Dr. Arabi, and this is a short presentation and review of the uh, management of penetrating brain injury, either conservative or surgical. We decided to use the guidelines for the management of penetrating brain injury, which was published in 2001 in Journal of Trauma, and also add to that our experience at the shock trauma for the past 20 years. We know that only 10% of patients with penetrating brain injury due to civilian gunshot wounds survive, and we know that we have to do our best to save those 10% of patients. We have selected 9 examples of the current experience with penetrating brain injury, and we decided to explain how we do manage these 9 varieties of penetrating brain injury, which is a heterogeneous group of patients. One of the fundamental issues of management or surgical management of penetrating brain injury is to know the extent of your trauma. We have tried to present to you 9 different cases of penetrating brain injury with different significance and extent of trauma to the brain. Patients who have very little injury to the brain itself. These are injuries with small entrance wounds. These injuries are not associated with a tremendous change in level of consciousness. The size of the entrance of these injuries is less than 1 inch in diameter. There is no major significant shift of the midline structures from right to left or left to right. There is no effacement of the basal cisterns, and there is no massive destruction of the brain or retention of bone fragments. On the other hand, patients with massive injuries to the brain, whether it is a single lobe or multiple lobes, major retention of bone fragments, brain destruction, or intracerebral hematoma. These injuries need major attention, and the surgical planning and surgical technique has to be specific for each one of those penetrating brain injuries, therefore preventing major complications such as CSF leakage or traumatic aneurysms. On the other hand, significant penetrating brain injuries have major retention of intracranial bone fragments, destruction of the brain, destruction of the skin, and fragmentation of the skull, retention of bone, and presence of major metal or bone fragments inside the brain. These injuries must have major debridement, including evacuation of the necrotic brain and the superficial bone fragments, the track of the penetrating fragment or bullet needs to be cleaned copiously with saline, followed by watertight closure of the dura, replacement of the bone if it is not fragmented, and also a watertight closure of the skin. In patients who have significant destruction of the brain, when there is evidence of an intracerebral mass such as bony destruction and intracerebral hematoma, that we don't know what is going to be the natural history of this mass. And in patients that their level of consciousness is not easily determined because of sedations and muscle relaxants, or if we suspect that there is going to be evidence of increased intracranial pressure, ICP monitoring has to be performed. The best way of ICP monitoring is IVC by external ventricular drainage, and this could be performed before surgery or after surgical intervention. If the ICP is above 22 millimeter of mercury immediately after a gunshot wound to the head, there may be a need for decompressive craniectomy. If not, the ICP monitor could be placed and ICP monitoring could be continued until the ICPs are manageable. Decompressive craniectomy could be either planned or under acute conditions to buy some time for transfer of the patient to major trauma centers in Europe or inside the United States. Preemptive decompressive craniectomies are usually performed immediately following search and rescue of the victim. The preemptive decompressive craniectomy is usually performed if there is significant shift of the midline structures, if there is evidence of acute subdural or intracerebral hematoma, and if there is obliteration of basal cisterns, indicating there is going to be impending uncal herniation. If the penetrating brain injury involves multiple lobes and the patient seems to be stable, there is no significant shift of the midline structures, and there is not complete obliteration of the basal cisterns, then we can monitor the intracranial pressures. And if the intracranial pressures increase more than 22 millimeter of mercury, then planned decompressive craniectomy is performed at that time. Decompressive craniectomies are performed in nearly 10% of patients whose post-resuscitation GCS is acceptable and is between 6 to 15. Following decompressive craniectomy, there is need to repair the dura, and usually cranioplasties are performed after 3 to 6 weeks, and preferably with plastic, PEEK, capital P-E-E-K, and less likely using the patient's bone, because of contamination or fragmentation of the skull of the patient. Patients whose major traumatic brain injury is associated with intracerebral hematomas. These patients should be evaluated and should be studied for evidence of vascular injuries, including arterial injuries. Arterial injuries could produce traumatic intracranial aneurysms. Traumatic intracranial aneurysm need to be managed by endovascular surgeons or endovascular radiologists, and at times should be managed by open surgical intervention. Another significant aspect of penetrating brain injuries is involvement of the air sinuses or mastoid air cells. In that case, we have to have the assistance of other disciplines, including plastic surgeons or oromaxillofacial surgeons, in order for complete exposure and closure of the dural defect, craniotomy, and in case there is a need, to have vascular flaps turned to cover the entire defect of the damage which was done by the penetrating brain injury. In this case, there has to be an attempt to repair the base dura, and if there is need for decompressive craniectomy and evacuation of subdural hematoma, this should be performed, followed by cranioplasty. If the postoperative course of patients with penetrating brain injury is complicated by CSF leakage from the nose in the form of rhinorrhea or otorrhea, and if there is evidence of CSF leakage from the patient's wound, these patients need to be taken to the operating room immediately for repair of the dura and prevention of deep intracranial infections. One of the controversial aspects of treating penetrating brain injuries is usage of prophylactic antibiotics. Although not ever studied by a randomized trial, there is plenty of case studies, and these case studies relate to World War II, Vietnam, Korean, and the current Middle East campaigns. And in all these current and distant surgical managements, usually the prophylactic antibiotics have been used. And the current recommendation of the guidelines for the management of penetrating brain injury is also to use prophylactic antibiotics for prevention of deep central nervous system infections, and when there is CSF leakage, to prevent meningitis. The timing and the type of prophylactic antibiotics is not specified. We at the shock trauma usually use between 3 to 5 days of prophylactic antibiotics when we treat the penetrating brain injuries conservatively or surgically. Okay, one of the questions which is always presented to us is, what exactly is the significance of retained bone or small metallic fragments? We really don't know. We know that in the studies of Cushing and during World War II, Vietnam, involvement of Israel in the Arab, in the Lebanese campaigns, and also in patients from the Iran-Iraq War, there is between 10 to 50% incidence of retained bone fragments in post-operative CT scans. It is agreed that in extensive penetrating brain injuries, the superficial retained bone fragments need to be removed. However, the small, deep retained bone fragments need to be left alone. In addition, there is evidence that small metal fragments should be left alone and not removed. The current recommendations of the guidelines for management of penetrating brain injury is also recommending that superficial bone should be removed and small distant bone fragments which are retained should be left intact. We have experienced during the past 20 years that this concept is true. We literally never seen patients coming back with deep CNS infections around the retained bone fragments if they are small. We tend to recommend the same concept for the civilian gunshot wounds to the head, and there is every recommendation to remove the superficial fragments, but the deep fragments need to be left alone.